Hello dear students, INI-CET November 2023 exam is over. Be relaxed. Dear doctors, so today I am going to discuss OBG part of INI-CET 2023 November exam, and here is a set of around 8 to 10 questions from obstetric part, and my colleague is going to discuss the gynec part. The first thing I want to tell you is that most of the questions is from my Alan OBG notes. Okay, doctor. And the questions from OBG, most of the questions are clinical vignettes. Now, first we'll discuss the first question in obstetric part. Yes, that is from physiological changes in pregnancy. That is, increased blood volume during pregnancy is due to. What is the cause for increased blood volume during pregnancy? One, the option A is increased aldosterone and estrogen. B is increased aldosterone and ADH. And C is increased retention by kidney. Yes, and D is increased retention by kidney, increased aldosterone and estrogen. What is the correct option? Now, dear doctors, in this exam, for this question, they given a graph, it seems. I am not able to get the graph, but what is the final take-home message? Increased blood volume during pregnancy is due to one, increased aldosterone. Yes, that is the one thing, and increased estrogen, and another one thing, increased retention by kidney. Please make a note of it. The option, suitable option for this question is the D option, that is increased retention by kidney, increased aldosterone and increased estrogen. Now, so I'm not able to get the graph which was given in the exam, but I can tell you what is the graph that is given in the exam. Now, doctor, look into this. This blood volume, please make a note of it. This blood volume starts to increase. Please make a note of it. This blood volume starts to increase around 6 weeks of pregnancy. Please make a note of it. This blood volume starts to increase around 6 weeks of pregnancy. Yes, and peaks around third trimester. So, peaks around third trimester means around 32 to 34 weeks. Yes, the blood volume will peaks. So, this is the graph would have been given in the exam. Understood? No? So, blood volume definitely increases around 40 to 45%. Yes, which is given in the Bible of obstetrics, that is Williams. So, it will start increasing around 6 weeks, peaks around third trimester, that is 32 to 34 weeks. And this increased blood volume may be due to increased aldosterone or increased estrogen or increased retention by kidney. I think this question is clear, doctors. Yes? Yes. Now, doctor, come to the next question. Yes, very nice question. So, 39-year-old, Gravida 6, Para 3, Abortion 3 with previous 3 LSCS with PAS. All of the following are complications due to PAS except. Now, dear doctor, what is this PAS? Doctor, PAS is also called as MAP. What is this PAS or MAP? So, PAS is, that is placenta accreta syndrome or placenta accreta spectrums. You got my point? So, placenta accreta syndrome or morbidly adherent placenta. So, morbidly, dear doctors, morbidly adherent placenta. Yes, PAS or MAP is nothing but placenta accreta syndrome or morbidly adherent placenta. So, we have got 3 morbidly adherent placentas. One is placenta accreta, increta, percreta. Understood, doctor? So, you all know, if you go through my video, most common risk factor, please make a note of it, most common risk factor for this PAS or MAP is what, doctor? Placenta previa in present pregnancy. Please make a note of it. Most common risk factor is placenta previa in present pregnancy. Second most common risk factor for this placenta accreta syndrome or morbidly adherent placenta is previous uterine surgeries. Either it can be a cesarean section or either it can be a myomectomy or hysterectomy, whatever it may be. Now, she is a Gravida 6, Para 3, Abortion 3 with previous 3 LSCS with PAS. So, all of the following are complications due to PAS. Definitely, due to this Akrita syndrome, there will be increased risk due to increased risk of bladder injury. Yes, increased risk of peripartum hysterectomy, increased risk of bleeding leads to increased risk of blood transfusion and increased risk of bowel injury also. But when compared to bladder injury and bowel injury, more chances of what? Bladder injury, because if you take that placenta percreta, that placenta percreta involves the cirrhosis of uterus, which involves the bladder mucosa also. That's why more chances of bladder injury compared to the bowel injury. Now, yes, if you see these 4 options, even it leads to bowel injury also, bladder injury also, more chance of peripartum hysterectomy. That is the definitive management of this Akrita spectrum diseases, and increased risk of more bleeding leading to increased risk of blood transfusion, and there is a chance of bowel injury. But suitable option for this question, I can go for what? Increased risk of bowel injury. Yes, increased risk of bowel injury is less compared to the increased risk of what? Bladder injury. I think this question is clear, doctor. So in NEET PG also they can ask you the question. You should very familiar with this. So placenta Akrita syndrome or morbidly adherent placenta is what, doctor? It is due to what? Placental implantation pathology. Placental implantation pathology. Here means in this condition the placenta is not only attached to endometrium, it is infiltrated through the layers of the myometrium up to serosa. That's why the definitive management of this condition is what, doctor? Peripartum hysterectomy. The most common risk factor is placenta previa in present pregnancy. Second most common risk factor is previous uterine surgery like cesarean section, myomectomy, hysterectomy. Understood, doctor? Yes, this placenta Akrita spectrum can lead to bowel injury, bladder injury, peripartum hysterectomy, increased risk of bleeding, that is PPH. Is it clear, this question? The answer for this question is increased risk of bowel injury. Now come to this question, that is infection in pregnancy. All of the following are teratogenic infection in pregnancy except, it's a repeat question. You all know this HSP, herpes simplex virus. It has got the intrapartum transmission is very high with HSV. But what about this chickenpox or CMV or rubella? They are all congenital infections. They cause more of congenital syndromes. That's why this HSV has got intrapartum transmission is highest with HSV. Intrapartum transmission is highest with HSV compared to this chickenpox, CMV or rubella, because this chickenpox, CMV or rubella have got congenital infections. Understood, doctor? I think this question is clear. Now come to this wonderful question. 35-year-old multi-gravida visits to labor ward casualty at 30 weeks. Please remember this period of gestation. That is at 30 weeks with history of painful vaginal bleeding. She is 30 weeks POG. Yes. So she comes with history of painful bleeding, that is antepartum hemorrhage. Then and also gives history not able to perceive fetal movements. Fetal movements are absent, and her BP is 164/90 with proteinuria 2+. Obstetric grip examination shows fundal height corresponds to 34 weeks. Here the fundal height is more than POG. So clinically look into this, her LMP as per clinical estimation she is telling 30 weeks, but as per her fundal height it is 34 weeks, means fundal height more than POG, and uterus is tensed, ridged and not able to auscultate fetal heart sounds. Pelvic examination, os is 6 cm dilated with 60% effacement. Next step in the management. Now dear doctor, what all the catchy points here is, one is the fundal height more than POG, that is an important point, please make a note of it. The fundal height more than POG, that is a one thing, and absent fetal heart sounds, yes, and hypertension, and she is in active phase of the labor. Please make a note of it. So as per ACOG, dear doctor, active phase of the labor is nothing but more than or equal to 6 cm dilator. Please make a note of it. So fundal height more than POG, absent fetal heart sound, hypertension, yes, BP is 164/90 with proteinuria 2+, maybe preeclampsia. So and she is in active phase of the labor. Now what is the diagnosis of this question, doctor? Definitely it is concealed variety of abruption. Please make a note of it. What is the diagnosis of this question, doctor? It is a concealed variety of what? Abruption. Now dear doctor, in concealed variety there is RP clots. You all know, doctors. So if you see my videos, I nicely explained with the line diagram, there will be what doctor? RP clots. What is this RP clots? It is nothing but retroplacental clots. Now this retroplacental clots produces two things. One is thromboplastin, yes. Another one is thrombin. Another one is thrombin. Now doctor, this thromboplastin and thrombin, they all serves as a uterotonics. They all serves as a uterotonics, that is increases the tone of uterus, increases the tone of uterus. That's why uterus is tense, tender and rigid. Tense, tender and rigid. So due to RP clots, definitely this RP clots, it will infiltrate through the layers of the uterus. That's why the fundal height will be more than POG. Now doctor, if you see, one of the indication for doing ARM is in abruption. Definitely we will try to do what ARM. What is ARM? That is artificial rupture of membranes. Means if you do ARM, definitely the process of abruption gets stopped. And you all know most of the women in abruption, they are all in active phase of the labor. Why they are in active phase of the labor? I told you, due to RP clots, there will be release of thromboplastin and thrombin. They are all uterotonics. Means they will make the woman to progress the labor. Understand? That's why they are most of the women with abruption presents in active labor, and if you do ARM in abruption, definitely this ARM will stop the process of abruption in most of the women, as the Bible says. You got my point? If you do artificial rupture of membranes in abruption, definitely the process of abruption gets stopped or the process of abruption get altered. That's why one, we will control BP with antihypertensives and do artificial rupture of membrane. The answer for this question is do artificial rupture of membranes. So most of the students will try to answer, sir, control BP with antihypertensives and do immediate cesarean section. Yeah, you will think immediate cesarean section. See, in placenta previa, we will prefer to go for immediate cesarean section. But in abruption, we will try to do vaginal delivery because most of the women with abruption will be in active labor. Please make a note of it. Once, doctor, look into this. If you do artificial rupture of membranes, yes, the abruption process will be stopped. That is the release of thromboplastin, thrombin. Because more thromboplastin, more thrombin leads to what, doctor? So disseminated intravascular coagulation. That is consumptive coagulopathy. So that's why we will rupture membranes. Understood? So definitely we will rupture membranes in abruption, but we won't rupture membranes in placenta previa. Understood? Never ARM in placenta previa, must ARM in abruption. Understood? This is the take-home message from this question. Is it clear? So if such questions comes in your NEET PG, please be careful. So once again, take-home message. Dear doctor, abruption women will present with painful vaginal bleeding. And one of the risk factors for abruption is hypertensive disorder. That is the one thing. And most women with abruption definitely presents in active labor. Why? Due to release of thromboplastin or thrombin. And definitely we will do what ARM to alter the process of abruption. Is it clear? Yes. So next, very good question. An intern was conducting vaginal delivery, inadvertently leads to uterine inversion. The next best step would be, doctor, if you see my video, that is the third stage labor complication, in that uterine inversion, the first line I told you in the management of uterine inversion is never attempt to remove the placenta. Please make a note of it. I used to tell many times to my NEET PG aspirants under the topic of uterine inversion, never attempt to remove the placenta. Understand? First, you replace the uterus inside, then you try to remove the placenta. Please make a note of it. Never attempt to remove the placenta. Never attempt to remove the placenta. That is the first important take-home message in the management of uterine inversion. Understand? That is repositioning the uterus without removing the placenta. You got my point? That is, so first, never attempt to remove the placenta. Then, manual replacement of uterus under general anesthesia. Please make a note of it. Manual replacement of uterus. Manual replacement of uterus under general anesthesia. And another important point, what is the technique we will follow? The part which is delivered first is what, doctor? Replaced last. Please make a note of it. Please make a note of it. The part which is delivered first, which is coming out first, The part which is delivered first. So, which is that part which is delivered out first, doctor? It is a fundus. The part which is delivered first, that is the fundus, is replaced last. Is replaced last. So, these are all the catchy points you should know under uterine inversion, and most common cause of death in uterine inversion is hemorrhagic shock. It is not the neurogenic shock. Please make a note of it. It is a hemorrhagic shock. So, first the answer for this question is yes, we will manually replace the uterus without removing the placenta. Means never attempt to remove the placenta. That is a one important point. Is it clear? Yes. Now come to this. I think this is a forensic medicine question, but anyway I will discuss the two important golden points on this question. 13-year-old female was brought to OPD by her mother. Yes, upon examination she was found to be 8 weeks pregnant. Yes, so it is 8 weeks pregnant and not willing for genital examination. What is the most appropriate next step? So, preserve the clothing. Yes, register a MLC and inform the police. Take consent from the mother for examining genital organs. Plan MTP immediately. You all know, doctor, as per POCSO Act, less than 18 years pregnant definitely will intimate the police and make it as a MLC. Yes. Is it clear, doctor? As per POCSO Act, less than 18 years pregnant definitely will intimate police and register for what, doctor? MLC case. You got my point? Is it clear? It's a direct question. So, you should remember the POCSO Act, and less than 18 years definitely make a MLC and inform the police. These are the two catchy points from this question. Yes? Yes. Now, look into this question. A 36-year-old pregnant mother with known psychiatric bipolar disorder on lithium therapy, that is 750 milligrams per day, presents to labor casualty at third trimester. Yes, that is the one thing. No issues or attacks since 1 year. What is the next best step? Doctor, if you look into my OBG videos, 2 drugs in obstetrics is very important. Please make a note. Very, very important. 2 drugs. One is lithium in pregnancy. Definitely you should know. What is the dose? What is the toxicity? Yes, everything is important. Lithium in pregnancy. That is very important. And another one important, indomethacin. On and off, dear doctor, indomethacin in pregnancy. On and off, the questions on these 2 drugs will be coming. Please remember. In NEET PG also, either they can ask you question on indomethacin, either they can ask you question on lithium. Understood? So, now this time they are asked the question on lithium. Now, the pregnant mother who is a known case of bipolar disorder on lithium presents to labor ward casualty at third trimester. What is the next step? Dear doctor, any pregnant mother on some drugs which will be somewhat teratogenic during near term, definitely we will reduce the dose. Why? To decrease the neonatal toxicity of the stroke. Please make a note of it. So, you got the point, doctor. Now, she presenting at third trimester. And so, most of the drugs in pregnancy near term will reduce the dose, because due to the effect of that drug on a neonate. Understood, doctor? So, we will decrease the dose of lithium to prevent neonatal transmission or to prevent neonatal lithium toxicity. You got the point, doctor? The answer for this question is decrease the dose of lithium. Understood, doctor? Please make a note of it. For NEET PG, try to read golden points on lithium in pregnancy. Yes. And what? Indomethacin in pregnancy. Is it clear, doctor? Yes. Is this question is clear? Yes. Now come to this another important clinical vignette. 29-year-old primary gravida visits to labor ward casualty with history of pain abdomen at 39 weeks of POG. Pelvic examination reveals 3 cm dilated, 70% effacement at -3 station with bag of worms felt. Doctor, if you see, whenever in your final years or in your internship, the consultant would have told you bag of worms is always characteristic of umbilical cord feeling. You got the point, doctor? So, it is bag of worms is nothing but umbilical cord. Here it is 3 cm, 70% effaced, yes, -3 station with bag of worms felt. Doctor, bag of worms felt means definitely it is umbilical cord, and the diagnosis of this question is it is umbilical cord presentation. It is not umbilical cord prolapse, it is umbilical cord presentation. So, what is this umbilical cord presentation? Means in this the membranes are intact. Please make a note of it. Membranes are intact. But in umbilical cord prolapse, the membranes are not intact. That is, the membranes are ruptured. the membranes are ruptured. But then this question, 3 centimeter dilated with 70% efface with -3 station with bag of worms felt, definitely it is umbilical cord presentation. Doctor, if you look into the topic in the OBG, that is in the induction of labor, I clearly mentioned the contraindications of labor. I clearly mentioned the umbilical cord presentation is one of the contraindication for induction of labor. You got my point? Miss, definitely in umbilical cord presentation, we won't go for induction of labor or we won't go for artificial rupture of membranes. Only thing is what, doctor? We will do immediate cesarean section. She is already 39 weeks, yes, with 3 centimeter dilated, with 70% effacement, with -3 station, with bag of worms, definitely umbilical cord presentation. So, umbilical cord presentation is an absolute indication for what? Immediate cesarean section. Is it clear? The question is clear? Yes. So, I think, so these are all the 8 questions which I collected under obstetric part. So, dear doctors, my humble request, so most of the questions in obstetrics and gynecology will be clinical vignettes. Understood? So, easily solved. Understood, doctor? So, anyway, the gynec part will be discussed by my colleague. So, I tried to cover the maximum authenticated questions of INI November obstetric part. Understood? So, dear doctors, thank you and revise for my NEET PG exam. Thank you, doctors.